Good evening, everybody. I'm just super excited and happy um, to see everybody virtually and to do a presentation. Um, this is a this is a really good topic, and I'll kind of explain a little bit why U Chicago is it's important to kind of get a sense a little bit of some of the unique treatments we have for incompetent cervix or cervical insufficiency. So I'm excited to you guys already kind of are aware of it, but I'm excited to tell you guys more about it. It says recurrent pregnancy loss, but I really want to just clarify that we're going to hone in on a very subgroup of patients because recurrent pregnancy loss could encompass many other things. So it'll be kind of a subset, and I'll explain a little bit more in just a moment. So our goals today, we've got several of them. Oh, sorry, let me just make sure I'm toggling where I should. Okay. So our starting slides. I have no disclosures for today. So we've got several objectives. I really want to make sure that we can understand what cervical insufficiency is, what maybe could be some warning signs of it, because it's a little bit of a sneaky and challenging diagnosis, and what can we do about it? So when somebody has this diagnosis or this has happened to them, there are a couple different avenues of treatment patients can pursue. I'm going to speak a little bit more about transabdominal cerclage because that's the hat that I wear, but obviously we'll go through a little bit about maybe what's confusing about transvaginal versus transabdominal. So we're going to talk about that and want you guys to feel comfortable knowing the differences and who maybe is a good candidate for which one. And to look at more closely patient care. What does this involve with patients coming in? Because we have such an amazing program, we do have patients that travel nationally, internationally for our program here. So kind of for everybody to be up to speed on it, regardless of who that patient may interface with, I think is really important. And then also, how can we support patients with this diagnosis? You'll see it's a very uncommon diagnosis, and it happens in such a very sensitive and challenging part in a patient's pregnancy. We've got a big agenda, but we're going to discuss key features, look at evaluation and treatment, and then talk about how we can be a team and approach these patients together. So what is it? So before I define incompetent cervix, again, I'm just going to quick clarify, this is considered part of recurrent pregnancy loss. Recurrent pregnancy loss can encompass first trimester and second trimester losses. So just know that we are not going to be talking about first trimester. That's going to be a miscarriage or pregnancy loss before 12, 13 weeks. We're going to be in the second trimester. So kind of from here on out, it is second trimester losses, and more specifically, the etiology of or the diagnosis of incompetent cervix. So what is it? Because there is not much that can really impact a patient in the second trimester significantly when it comes to preterm labor or pregnancy loss than when you have a cervix that's insufficient. It's a terrible mean name, but it essentially means that it's a mechanical problem where once the weight of a growing pregnancy is placed sort of down, exerts its pressure on the top of the cervix, it begins to sort of open and dilate and thin out, or effacement is another word for that. This happens prematurely. We know there is a time and place for that where the cervix is supposed to soften and dilate, but it is not in the second trimester. It occurs without contractions, and we'll talk a little bit about how that can be sometimes confusing in a patient's presentation. But it is not labor that causes the cervical change. It is the cervical change that happens first, and then there's a cascade or a downward effect that happens later on when the presentation happens. This is in the second trimester. So essentially we can say it's very painful, insidious cervical dilation that leads to pregnancy loss or preterm delivery. The time frame, 14 to 24 weeks. Again, we're kind of targeting more of that second trimester. And we talked about how it's kind of painless and insidious. Now, I would say the start of it is challenging, right? Because it's very, very quiet. But common scenarios that I hear is that patients may notice, say at 16 weeks or 18 weeks, they said, well, I was noticing a little bit of increased vaginal discharge, didn't think much of it, was told everything was normal. Then I started to get like some kind of low back pain, wasn't too painful. felt like the pregnancy was sitting really low, just something felt odd. Well, it's not really painful and it doesn't alert to anything severe, right? These are very kind of subtle symptoms. At some point, because the progression of the dilation and essentially the sterile environment on the inside of the uterus is coming into contact with the outside environment, like the picture towards our right? You see that bulging bag of water. At some point, an ascending or a tracking infection is going to occur, or a subclinical infection, and the body's going to begin or finish that pregnancy loss. It could start with maybe some more painful contractions. All of a sudden, they notice vaginal bleeding or spotting, and things kind of cascade from there as the body's getting ready to deliver, because the body knows that it's been compromised. And in order to prevent some severe sequelae from the cervix hanging open, a delivery or a miscarriage is going to happen. I did find this interesting picture over in AJOG right here. So you can see, I don't know if you can see my cursor, but this is what it looks like if you were to do an exam on a patient, like a speculum exam. Obviously the cervix is supposed to look like a closed donut, but right here you see the kind of like yellowish tan sac. So it's sort of, we call it a bulging membranes or a bulging bag of water. This picture right here is identifying a patient who had an incompetent cervix that was identified. They have to kind of pull the lip of the cervix that remains because of the effacement or the thinning out, and they put in what's called a rescue transvaginal cerclage. Because if you can see the cerclage within a vaginal exam, that is a transvaginal cerclage. And you can kind of see the picture towards the right. It's very red, I realize. The picture towards the right, you kind of see that it's kind of strung shut and enclosed. And so that would be a rescue transvaginal cerclage. But you can kind of see how overt that bag of water is that's bulging, because there's no strength or integrity left within the cervix. It is sometimes a hard diagnosis to catch when a patient's in the middle of a loss. There could be a lot going on, or bleeding, and is there an abruption, or what's happening. But most of the time, as the dust settles and you start to look back retrospectively at the events that happened, you start to get a better or clearer picture. And sometimes there needs to be other workup done, checking for any other signs of infection. Sometimes too, again, can be a little bit sneaky, but if they have a presenting, it's kind of a severe premature delivery, always in the back of your minds, think, was there something with the cervix that just happened to present a little bit later? It is rare. It is not common. So I generally tell patients it's about 1% of all pregnancies. So it is really uncommon. It feels very, very common in my world, because that's who I talk to every day. But it's not common. And again, one of the hard parts about this diagnosis is that there's no test before pregnancy that you can take, or an ultrasound that you can do. Everything generally looks normal, but it's a mechanical or functional problem. You don't really know it's an issue until you're really smack dab in the middle of a pregnancy loss, which is really hard and heartbreaking. So there's not really a clear cause. Again, for me, I suspect anything in that second trimester that has to be on the differential of potentially the etiology of what has happened. We've looked, there's not a lot in the literature that says what predisposes patients to an incompetent cervix. If somebody has had many cervical excisional procedures, right? So say they had a cold knife cone, they had a LEEP and then a cold knife cone, they have multiple excisional procedures. Absolutely, you're really removing pretty much any ectocervix or vaginal cervix left. So those patients are at an increased risk. What do we do with patients who have had one LEEP procedure? Generally, we think that, one LEEP procedure in your lifetime isn't too extreme. But could it be that if they had a patient has an underlying genetic predisposition and a LEEP procedure, could that complicate the way that you manage or manage these patients? Certainly, if there's a uterine anomaly, congenitally patients are born with their anatomy being different, then potentially that has a larger impact. I forgot to mention, along other cervical excisional procedures, patients, again, trachelectomy, they've had cervical cancer, they've had pretty much the large portion or majority of their cervix removed. they are obviously going to be at risk for having this issue as well. And then kind of the frontier of looking ahead, obviously genetic predisposition, we tend to say that the catch-all of, maybe there's some predisposition. I don't generally see that it always runs in families. I do have some siblings that have had it. I always ask, anybody else in the family had this problem? So sometimes I will see some family history, but not commonly. Again, it's an uncommon diagnosis. More is known about it now. Maybe people didn't know much about it 10, 20 years ago, so it's hard to say. Could there be some connective tissue disorder of that predisposition? Or if you already have that predisposition and you have a connective tissue disorder, is that the perfect storm as well? So all things I ask patients, these are all really important questions that we need to know about patients if they have potentially this history. So we just talked about a few patients with their clinical scenarios, and it can be, again, I hear these stories every day, some low back pressure, a patient lays down and all of a sudden their bag of water breaks and they go to the labor and delivery and they're pretty much delivering on the way to the hospital. Could be some mild stomach cramping, all sort of these kind of subtle signs that the pregnancy is shifting down and getting lower. Vaginal discharge, so common to hear about this in pregnancy, but sometimes that precedes a little bit some of these other bigger warning signs, or some little bit of spotting. Again, spotting can happen normally in pregnancy. Tend to worry about that a little bit more as patients progress in that second trimester. If you see the picture over here towards the right, this is a nice graphic to try to explain a little bit, right? So you have a growing or developing fetus, heads down, vaginal canal right in here. Again, I'm assuming, hopefully you can see my arrow, and then the cervix right here. Part of, and I'll go over this even more, I think of the cervix as a cylinder, and part of what's so important about the cervix is its distance between a growing pregnancy in the sterile environment on the inside to, I call it the outside world, right? Vagina and beyond, where it's normally colonized by lots of different various bacteria. It's very normal. You need that cylinder in place so that the endocervical canal, right, that connection from the inside the uterus to the outside world, is able to aggregate a lot of mucus. This is biologically a very normal phenomenon that is supposed to happen in pregnancy, right? Pregnancy, lots of extra progesterone is produced by the placenta that helps thicken the endocervical mucus and kind of forms that plug. And there's a benefit to that. Again, it's the keeping the sterile environment on the inside sterile and the external world on the outside. So you can kind of see that yellow mucus plug right in here in that endocervical canal, because the cervix in this normal pregnancy is closed, it's maintaining length. If you shift over towards the right, vaginal canal here, and you start to have a little bit of that opening. And you see that opening is going to start to extend in here, because when you lose that closure at the level of the internal os, as the pressure is exerted, this starts to continue to open. Opens too much, you're losing that mucus plug there, which is so important for a barrier and protective mechanism. And the pregnancy will start shifting down. And sometimes that will take along the placenta, where we sometimes get that shearing effect and bleeding. And I've had patients describe all of a sudden they could feel the pregnancy or feet kind of touching or tickling the cervix a little bit. You really should not be feeling that. And if it's a patient's first pregnancy, they're going to have no idea that that is abnormal, because it's not painful, just feels a little bit strange. You can pick up on these signs, sometimes by history, what we just talked about. Ultrasound. I have a lot of patients who are going in for just their regularly scheduled anatomy ultrasound, right? At 18, 19, 20, 21, 22 weeks, anytime in that time frame. And it's pretty routine where you're going to look at a cervical length. And you can sometimes see that the cervix is measuring, it's short. And that can be a clue. Hey, it's less than 2.5 centimeters or 25 millimeters. There is sort of the peak, or that, I'm going to just shift, back to my last slide. With the cervix opening up, it can start to create like this funnel, right where this internal os widens and forms like a V. And so if you see that on ultrasound, that's a very ominous sign. The cervix is becoming dynamic. You should not be seeing that. So sometimes you can pick it up with an anatomy scan. Sometimes there's some warning signs, some subtle warning signs that we looked at on that prior slide. And then on exam, they see that the cervix is opening or the back of water is bulging, and then you can try to do some rescue maneuvers if possible, or ultrasound indicated transvaginal cerclage. Obviously, we'll talk more in a minute, but we're not talking about abdominal cerclage at this point. This is all going to be vaginal because it's during a patient's pregnancy. And then you try to rule out any other things that could have contributed to that pregnancy loss as well. So treatment. So I kind of think about this more simply. And so if you know you have this problem, if the cervix is weak, we have to put a cerclage in. So two different pathways right here. What we're so much more familiar with, and patients and physicians and just kind of nationally, internationally, are vaginal cerclages. That's the most common step patients will take when they have a diagnosis of an incompetent cervix. So there's a couple different kinds, Sherrod Carr and a McDonald. Most commonly, patients are going to have a McDonald cerclage. It's just the one that's more commonly placed, a little bit less morbid because you're lower in the cervix. You're not getting too high up where there's the bladder reflection or entering into the abdominal cavity. So again, if you can see my arrow here, I think about a vaginal cerclage as a purse string suture, right? So the suture, it's made of marceline. It looks like a ribbon. It's about a half a centimeter in width, but it's thin, so it looks like a ribbon. And the needle that you use is blunt, but it's able to pierce and get into the tissue. And if you look at the cervix in a different view, you kind of look at it like a clock, and you're going to go in and out through like a 12 and 3, and then a 3 to 6. And so you can kind of hop around, and you're going to close it again like a purse string suture. So this is going to go right in here. And again, when you think about the cervix as a cylinder, the bottom third is going to be in the vaginal area, right, where we do pap smears and exams, things like that. Majority of the cervical length, though, you do find that in the pelvic cavity. So more 2/3 of it is going to be found within the pelvis, but we're able to access the bottom third right here. So McDonald cerclage is placed right in here for a purse string closure. And then Sherrod Carr is a little bit different, where it does take some dissection of that bladder reflection. The bladder kind of overlies the uterus and cervix right here, where you're trying to get the cerclage up a little bit higher. So we're trying to get up to that source of that level of the internal os so that you can have a higher level of support. And then the second pathway, which is less common, is transabdominal cerclage, and we're going to say TAC for short. And the TAC is placed from the abdominal route. So if we just said, 2/3 of the cervical length is in the pelvic or abdominal cavity, then to get there, we have to go through the abdominal space. There, the goal is that you're placing the cerclage exactly right up at the cervical uterine junction, up at the very top. So we want that high level of support. When we're comparing the two, makes sense, right? Transvaginal is a vaginal route, transabdominal is a transabdominal route. Getting them in is very different. Yes, they're both cerclages, but they're a very, very different procedure. So vaginal cerclages, again, timing, you have to be placed during pregnancy. In general, there's some variability, but in general, it's about at 12 to 14 weeks gestational age. Their goal is to place it after the first trimester, where you're kind of weeding out potential first trimester miscarriages, which is, again, an unrelated problem to what we're talking about right now. And that all the genetic testing and everything is normal. Then patients are going to undergo this procedure. It can be done in the labor and delivery ORs, procedure rooms, and you have a spinal or a regional anesthesia, so not a full anesthesia. It is considered first line, right? So whether a patient has a history of incompetent cervix with this diagnosis, they see a short cervix on ultrasound, or they see a certain dilation on an exam, this is the indication for using this type of cerclage. Vaginal delivery, you still can keep the vaginal delivery option intact. So when I kind of toggle back to the picture, if If you have a vaginal cerclage and I can see it vaginally, you can cut it, and then the suture or the cerclage is pulled out, right? So then you still can access this end of cervical canal. Same thing with Schrodkar, you're gonna snip it, and then the whole band comes out. So you can still maintain a vaginal delivery. Generally, it comes out around 36 weeks or so. The nice part about it is it's vaginal. You don't have to go through abdominal wall. There's pretty minimal recovery. It takes like a day or two, perhaps after the procedure, but really, really minimal after that. You do have to get it replaced again in the next pregnancy. And then the risk is, it's a potential failure. So when you're down pretty low, right, you're at the bottom third, your goal is to help maintain as much length as you can in pregnancy. For some patients, and we'll get into this a little bit more, for some patients that's not quite enough, and they may still fail that. And so I think that's always where, um, a lot of times the role of the TAC or transabdominal cerclage with patients have had, any part of that vaginal cervix removed, right? So just imagine we X'd out everything here in that vaginal canal, then you would have no place to place a vaginal cerclage, whether they've had LEEPs or cones or trachelectomies. For those patients, they obviously they cannot have a vaginal cerclage. As you can imagine, when we talk about an abdominal cerclage, you do need to have a general or full anesthesia for it. We talked about, right, if you don't do well with the transvaginal or you've had other procedures, you don't have the vaginal ectocervix there, you're going to have to go up a lot higher, and that makes sense. While there's some rare cases we'll place them in pregnancy, we really, really, really need patients to come before pregnancy. And once you start seeing cervical change, it is not an option to place an abdominal cerclage. Must have a C-section. There's no other way about it. And it's because it's an incision and it's an abdominal approach, you do have a couple weeks for recovery. You can use it for future pregnancy. So once you do the work to get it in, you do not have to get it replaced again. And not just for recurrent, for other pregnancies, it does very well in pregnancies with multiples, twins. It does complicate if you, heaven forbid, have other problems that develop in pregnancy and you'd have to evacuate the uterus. It can complicate those rare circumstances where the band may have to be cut surgically, so you can open up the vaginal canal or cervical canal, or a mini C-section, which is hard. But because of the location, and we'll go back to that initial slide, because of the location is up here at the cervical uterine junction, where the support is, it yields very, very good results. So it has a really good support from the placement that it's located. But you can see the only way you can access it again is through the abdominal route. So this is a really good chart to look at differences. So you can say, yeah, obviously they're both cerclages, but they're very different ball games on either end. Looking at what it looks like, right? Because not a lot of places do abdominal cerclages. That's one of the hats that I wear here. And so I'm always excited to kind of talk about how we place them. For something that is not very common, it is a pretty low-tech tray that we use. We don't have too many gadgets and gizmos for this particular one. And the incision generally is about 4 to 6 centimeters. So I took a nice picture of a patient where you can kind of see this is the lower pelvic area. So a C-section is kind of in a similar or fan and steel area. This is going to be pretty low because the goal is to actually get through the layers, get to the top of the cervix for placement. This is obviously the uterus over to the left. Here's the Merceline band that we were talking about. It looks like a thin ribbon. And this is the front or the anterior cul-de-sac right in here. This is my best attempt at graphics here. But if you were imagining the cylinder or the cervix is heading here towards the patient's legs, the uterine vessels are right in here. So that's a little bit of the tricky part of this procedure, is that you are very close in the space where the main blood supply to the uterus is. So you have to be very careful and know exactly where you need to be. If the vaginal portion of the cervix is down here, you're going to see here in a second that we're going to tie that band down up here at the top of the cylinder. So we're not going to be down here, we're going to be up at the top. Okay. I'm going to use this time just for a teaching point again that this endocervical canal, I know it's a tricky concept, but the endocervical canal right here within the cylinder, which is your cervix, the band is going to be tied around the cylinder. So unlike the vaginal cerclage that I keep describing as that purse string suture that closes or occludes the canal, this will just be tied around it. So when I'm around it, I'm not in the cervix, I'm around that tough fibrous tissue. The cervix is different in texture from the uterus. So the soft part of the uterus that's to the left, if you touch it or pinch it, it's spongy. The cervix, as you go further down, is tough. So if you kind of tap the tip of your nose, right, that's a little bit of an analogy of that it's a little bit of a tougher texture that you can feel. So that actually helps me when I'm placing an abdominal cerclage. As I'm feeling for the location, I know where the cervix is transitioning into the soft uterus and where it is still kind of firm and fibrous. So if you're tying something around the cylinder, can you still have normal menses? Yes. Can you still pass an IUD? Yes. The canal has not changed. It's still open, it's still patent, it's still normal. Um, Another common question is once a patient has a tag, right, this band that's in, say they have a first trimester miscarriage that's unrelated to this initial problem that we're fixing. And can they have a D&C or what happens? And that's completely normal. So kind of less than 13, 14 weeks, a normal suction D&C can still be performed safely. And it doesn't impact the tech. That canal or that cylinder is still open because you can navigate. And then you tie it down just like it's your shoelace. But again, this picture illustrates that you can get an instrument in between where you tied it down. Like if you're looking at your shoelaces, you can put it in between the knot and your shoe, and it's not strangulating or closing anything off. Okay, but it is secure and it is tight. This is the back Marceline band. You can kind of see it's very close in color, obviously, to the cervix, but you can see it's the belt. Describe it as a belt around the cervix. And that's about it. You can see it on ultrasound, which is kind of nice. So if you see, this is a patient who actually is pregnant. So you can see the pregnant uterus over here towards your left. And then it is, these hypoechoic areas of white, and the endocervical canal right in here. Okay, but you can see sort of the bands on either side, which I think is always really fun to show the patient. Same thing right in here, right? This is the top of the cervix. The rest of the ectocervix is all the way here towards the right. And then if you're doing a cross section of the cervix, again, analogy of the cylinder, it's the best I can do. You can see the band right here. Depending on what slice that you get of the cervix, if you kind of move your hand a little bit, you could follow it all the way around, but it shows that it's applied nice and snug, but it is not in the cervical stroma. So the uterus and the cervix, ovaries, everything is going to function and be the same. So now that you have a sense of what it looks like for a patient to get a tag, we're understanding the post-op care is really important. And you can save this slide, take a picture of it, because while we're talking about this transabdominal cerclage through a mini laparotomy, you could really extrapolate this to many other procedures. But sutures are dissolvable. They're going to be sealed off with Dermabond to keep the skin clean, keep those incisions clean and dry. These are all things you guys go over with patients. The Dermabond is like your skin layer, so it's going to peel off in a week or two. It's okay to start washing with a washcloth at that time. And people should look at incisions every day. If they're squeamish, they should have a partner or somebody else look at it for them. Narcotic pain meds, most people are off within 3 to 5 days if they take it. I would say half of my patients never do. The other half will maybe take a little bit. And that's kind of for the average person. I think that's really reasonable. Alternating with anti-inflammatories, Tylenol, of course, I can't say this enough. Heat packs, ice packs are so incredibly important adjuncts to pain management after procedures, and especially after this procedure. It's very intuitive, right? You're going to gradually increase your activity level to start heading towards your baseline. Most people within 1 to 2 weeks are feeling good. And I always call it, there's a time when you start to forget you had surgery, and that's a really important part of the recovery. But really, no more knows after 4 weeks, including if patients are wanting to start their families or attempt to conceive. Once the band is in, I'm not doing, unless there's other things, I'm not doing any other procedures on the uterus. So they really can actually start to conceive very quickly. Bowel function, I could talk a whole nother hour about bowel function. This is sort of in everyone's corner when patients are recovering from surgery. And so this is no exception from a procedural standpoint. Return of bowel functions is so important. So patients need to be keeping up their end of the bargain. They need to be walking, right? Walking stimulates bowel function, hydrating, drinking tons of water, taking stool softeners, doing sort of natural remedies at home. Start drinking your coffee, start drinking hot water with lemon, everything we can to kind of promote bowel function. If a bowel movement doesn't come in 1 to 2 days, you hear me say this. People who work with me all the time are probably laughing because I cannot emphasize this enough that um, you have to be persistent and look at your instructions, have them follow that, and they need to start having a bowel movement either with enemas or suppositories. So they need to be very, very aggressive. Bowel function, if it does not return, makes patients bloated. Bloating is really, really painful on an incision, especially an incision like that. So this goes for any surgery, but always keep this in mind. And then it's really hard to tell, like, are they having pain because of bowel function, or is there something wrong with surgery? So first things, if anybody has abdominal pain, you've got to ask about bowel patterns, bowel habits. And then shifting gears a little bit with this diagnosis, when I was on the internet preparing for this talk, I talk to patients all the time about this diagnosis, and it's really challenging because a lot of what I hear from patients is that they feel that they had these symptoms. It really caught them off guard, and it takes a while for people to figure it out. Once you're figuring out what's wrong, you have to come to terms very quickly, most often that you are losing your pregnancy. And it's happening in the second trimester where patients have started to feel fetal movement. They've had normal genetics. These are overwhelmingly normal babies, normal chromosomes. There's nothing wrong with them. And they've had their gender reveal parties. And so it really is, it's a challenging diagnosis, and it's not talked about. It's also not on people's radar. So I think the more people are aware of this problem, with this condition, while it's not common, we can still kind of apply, empathy and, trauma-informed care for these patients. Because it's something that marks them, it's something that you just don't get over as a patient when this type of thing happens. In some patients, it happens more than once. And obviously, because of the space I practice with abdominal cerclages, I will have patients who have a second trimester loss, and then they get a vaginal cerclage, and then they lose that pregnancy, and then they come and see us. That is an uncommon, I always tell them it's an uncommon diagnosis, and you were that rare patient that didn't do well. But it really, when it happens again and again, it's very heartbreaking. And patients a lot of times have guilt. They feel that, what is wrong with my body? I let my partner down. I let my baby down, my family down. Something is, they're failing somebody, and it's very shameful. They feel really, really terrible about it. So being aware of all of that comes comes with patients who have had these second trimester losses are very, very devastating. So of course, no one person can do everything. So I need everybody. We have to have a team approach to take care of these patients. I think one is everybody's an eyes and ears and has a certain perspective that they bring to the table that is so important. Um, in the OR, everybody has eyes and ears. If you see something, you say something. I don't care who you are, what level of training you are, who you are at as part of the team. Everybody is so important. And I can't tell you the times that somebody notices an equipment error or an issue or brings to my attention a sensitivity problem with the patient or a concern. All of those things are really important. So again, we rely on the team approach to care because it is not feasible for one person to do everything. And what can we do? We can be aware that this is a diagnosis. So today we're learning about what it is an incompetent cervix or cervical insufficiency is, why it's tricky. It can be hard to diagnose. So we just need to always keep our spidey senses up of, hey, is this a diagnosis that we need to be thinking about? Um, Medical assistance, right? We want to make sure everything is documented, make sure we know why they're there, who is sending these patients so we can always be in contact with their provider for after an abdominal cerclage care. If it's not something that's well known, we don't want that to be a barrier for patients receiving care. Um, be sensitive to patients. This is hard in the clinic too, where it can be really, really hard for them to be in a waiting room with somebody who they do see visually is pregnant, or if they're hearing heartbeats from the ultrasound suite, like other patients having their scans. And so kind of ways to say, is there a different place you want to wait? I can come and grab you. Just kind of being open, a little sensitive to some of the trauma that they have experienced. And if they felt that they weren't heard or their symptoms weren't heard, that we're here and we're listening, we're taking anything that they say very seriously. Same concepts for our nursing team. You guys do such an amazing job. I know you do a lot of those post-op calls and connection. You probably also see a lot of patients who've had care with us over the years. I always keep this open line of communication. Email me, send me a my chart message. I always want to know how patients do. One, so that we know how well our cerclages, our abdominal cerclages are performing. And also, I like that connection at the very end to see that they're doing well and they are growing their families in the way that they want to grow their families. So definitely from our nursing team, providing education, both pre-op and post-op, make sure everything is up to date. How can we get this patient ready for the OR in a timely fashion? I always say that of the informed consent process, yes, we sign their consents before surgery, but the informed consent process starts the minute they start engaging with our care team, with me, with our nurses. We're all informing them of what surgery entails, what are the risks and benefits. Postoperative instructions, anticipatory guidance, bowel regimens, stressing that again, and providing that emotional support. These patients can carry a lot of that anxiety with them heading into surgery. Sometimes when patients have lost several pregnancies, like the only time they're in a hospital gown or in a hospital setting, they've lost a baby. And so sometimes coming for our surgery, even though it is on a positive note and it's hopeful and we're optimistic for the future, just being in that hospital gown can be triggering and hard because it's been so challenging for them. And there's support groups. The great part about the digital age is that patients with a rare diagnosis can connect in a meaningful way and be support for each other. And we can be support for those patients as well. We are a team. This is me and Dr. Fisher. This is sometime during the pandemic. We're without masks on this one, so I chose it. Again, we cannot do this program with one person. We need all of our medical assistants, all of our nurses. I didn't get Karanda Craig's picture here, sorry, but a huge shout out to her. She's our program coordinator, who is our kind of front line for scheduling patients. And if there's any questions, we're always available to help answer them, take care of patients. Karanda is an amazing resource as well. So we are just really happy and excited about our program, and we work together. I think that is all I got for you guys. A couple take homes. Sorry, one or two more slides. Um, so closing to finish everything, I really want us to understand what it is this diagnosis is, because it can be confusing. And we said this is where the cervix opens up. It's a painless way, and it can kind of catch you by surprise. While there's some things that can predispose us, our patients to developing incompetent cervix, a lot of times we just don't know why this happens in one patient and not somebody else. And we just sometimes don't know it's a problem until it's happening. But where we can intervene is once we know that this is a diagnosis, then we can act. We can offer patients surgical management and options for how they want to proceed with their care in the future pregnancies. And then the timing is important depending on what option they're choosing for various reasons. We need to make sure they are connected to these surgeons or these providers so that they are adequately treated the next time around. Okay. That's all I've got. Thank you guys.